Imagine a scenario where a human body has had no kidneys. How would waste, toxins, excess water from the blood be efficiently removed then? Let's delve into the fascinating possibilities of a situation where there are renal failure cases, an artificial replacement of kidney functioning, dialysis. Dialysis cannot completely perform lost kidney functions, but to some extent manages its activity by means of diffusion and ultrafiltration to remove accumulated toxins from the body. Hi, I am Dr. Harshita, your host, and today we are honored to have the esteemed presence of Dr. Ajay Rathoon, a consultant nephrologist at Chennai Urology and Robotics Institute. Doctor has over a decade of experience and specializes in kidney transplantation, chronic kidney disease, critical care nephrology, dialysis, and many more. And today, Doctor will provide his valuable insights and shed light on the topic revolutionizing kidney care, the power of dialysis. We extend our sincere thanks for being with us today, Dr. Ajay.
Thank you, Harshita. Thank you for having me here. So today we'll be talking about dialysis and the myths, and I'll be talking about few things, and few myths are there about dialysis. So I tend to break few myths and share some lights about dialysis.
Yes, Doctor. Thank you. And let's proceed with our session. So, doctor, can you explain different types of dialysis modalities available and what factors influence the choice of dialysis for individual patients?
Basically, there are two type of dialysis. First is called peritoneal dialysis, and next is the hemodialysis. Peritoneal dialysis is the one where usually what happens is in dialysis there's a diffusion. So there's a membrane which differentiates two compartments. One compartment will be the where the capillary or the blood is there, and next compartment is a place where the dialysate fluid will be there, which is separated by a membrane. So this is and the particles move from the place where the less solute is there to the place of lower concentration to higher concentration to equalize it. So this is a basic principle of any dialysis. So let it be peritoneal dialysis or hemodialysis. So here there are two types. One is peritoneal dialysis and hemodialysis. In peritoneal dialysis, this membrane is a peritoneum, and in hemodialysis, it's an artificial membrane which we use. So basically, peritoneal dialysis is a slow form of dialysis which we have to do it daily, and it is like 2 to 3 sessions of at the maximum 4 sessions for each patient. And hemodialysis is something like we do it twice or thrice a week, so which will extend for 4 hours or 6 hours, whatever is necessary for the patient. So basically, we the choice is like peritoneal dialysis. We usually tend to lean towards peritoneal dialysis in kind of patients who have good patient care, like because peritoneal dialysis can be only be done in a patient who have a good home environment, because the care should be there in the home. So a good home environment should be there, and a good caretaker should be there. These are the two major prerequisites to do peritoneal dialysis. And in hemodialysis, basically it can be done in center, a good center with hemodialysis. The number of dialysis center right now are increasing now. It's extraordinarily increasing. So right now, even if the home care is not there, hemodialysis can be preferred for any patients. So these are the two major things. And in India right now, we have a major number of hemodialysis patients when compared to peritoneal dialysis patients.
Thank you, Dr. Ajay, for providing comprehensive explanation. Now, moving ahead, what are the potential benefits and limitations of dialysis method, and how do you assess the most suitable options for patients based on their medical condition and lifestyle?
First, we'll talk about peritoneal dialysis. So, as I said before, it is a slow form of dialysis because, as we know, hemodialysis we just do it weekly, twice or thrice. But peritoneal dialysis we do it like every day, twice or thrice a day. So, it is a very slow form of dialysis, and it's a very slow dialysis. So, it majorly where it is required or where the patient reaps a benefit is when a patient is a cardiac patient. So when a patient is cardiac patient, what happens is usually the patient's BP is very low. So in hemodialysis, what happens is there's an extra corporeal component. So when we remove a blood, so in dialysis unit around 150 to 200 ml of blood will be there in the dialysis unit. It will be in a rotation. So those patients who have very low EF, very low ejection fraction, they don't even tolerate this amount 200 ml of blood removing from their body. So they usually crash, or they'll have low, they'll have recurrent hypotension, they'll have recurrent cramps. So in these patients, they reap a benefit on having peritoneal dialysis. And next is access issues. When patient doesn't have any good access, they don't have AV fistula, proper AV fistula, they have a very bad artery and venous system. They have multiple central venous stenosis, or they have multiple IGVs, blocks, thrombus. They again, the next choice will be peritoneal dialysis. And pediatric patients, majorly pediatric patients, because they are school goers, so they can't just cut their school and come back to dialysis unit, because dialysis session is just 4 hours, but the waiting period will be again 4 hours. So they can't just skip school every time. Like they can't skip 3 days a week school. So again, CAPD comes, peritoneal dialysis plays a major role in school children's, who they can just put on a bag, go to school, come back for lunch, just put out the bag again. So it will be very easy for them. So school children's again we prefer. And very old age, like patients is like 70 plus or 80 plus, again we prefer peritoneal dialysis. So these are the specific conditions, few conditions where we prefer peritoneal dialysis. And again, in peritoneal dialysis there's a risk of peritonitis. So when a patient is having a recurrent peritonitis, or patient is having fungal peritonitis, we usually tend to remove the catheter, and we defer them about peritoneal dialysis. That is about peritoneal dialysis. And about hemodialysis, it is a robust form. Weekly twice or weekly thrice is enough. And whatever fluid is needed to be removed, we can remove as generously as we want. And the main thing is the heart should be good to tolerate hemodialysis. Uh, and the availability of centers, multiple centers in India, is it's going up again, and in a gradual rate. It is extraordinarily increasing. Every month we see new dialysis center opening up, and we see government investing so much of money into dialysis. So the number of dialysis unit is getting increased, and which reaps a benefit for the patient, because they have dialysis unit each and every corner. When you are in a metro city like Chennai, you have dialysis unit in literally every major street, have around 2 to 3 centers. Patient when and they don't have a good caregiver in the home, they reap a benefit about hemodialysis.
Have there been any notable advancements or innovations in dialysis technology that have positively impacted patient outcomes in recent times?
Majorly, we have to talk about AKI, because we are right now we are talking about intermittent dialysis, which we use it for CKD, and that's a bigger concern when you deal ICU, which is called AKI, acute kidney injury. There's something we used to have SLED. SLED is slow, low efficiency dialysis. We reduce the speed of all the speed of the dialyzer, speed of the blood flow, and we do it for patients who are sick. But it also has a limitation, like we can't reduce it to a limit where when the patient is having very low BP, they don't even tolerate this form of SLIT. There's a newer form of dialysis where we do it for 24 hours, which is called CRRT, which is continuous renal replacement therapy. You should have heard about it. And this is a very boom in your ICU care. What happens is, for example, in normal dialysis, the dialysate flow is around 500 ml per minute. So that is a flow of dialysate we keep. So the major player or the major factor in hypotension is the dialysate flow. So in SLED, what we keep is around 300 ml. So in normal dialysis is 500. In SLED, it is 300. But in CRT, we can keep it as low as 20 to 25 ml per minute. So that is the lowest we can keep. So the efficiency of the dialysis is going to be low, but it is going to be for 24 hours, or even we can have the dialysis for 72 hours in a continuum basis. So the dialysis will be going in a rotation continuously for at the maximum of 72 hours also. So that is one, and it has helped a lot in ICU care, and patients who are having acute cardiac infarction, like severe cardiogenic shock is there, even with triple inotropes also, we can go ahead with dialysis, CRT. And every year, or every 2 years, we having multiple new filters coming in CRT, which we have used it in COVID. So we had a lot of filters which we use in COVID, which removes endotoxin. Endotoxin is the one which reduces your BP. So that's a a filter called Oxaris filter, which we extensively used in COVID times. So it removes endotoxin, because endotoxin was the one, and cytotoxic storm was the one which killed most of the COVID patients. And this filter is the one which can remove cytotoxin filter, and this filter can be used with CRRT. So even when the patient BP is very low, we can use it. So there are multiple filters coming every year or two. We have multiple filters there. So a lot of innovations are going in CRRT. And in CAPD, as I said about PD, there's a mission called APD, automated peritoneal dialysis. It's a mission. So when a patient lies down, he can connect it to the machine and he can sleep up. The machine will do the whole exchange process. Even if the caregiver is not there for the patient, this machine can do that. And in the morning, he can just take it off and can put for the work. So it will be like just in the night he can do the peritoneal dialysis. So that is also another new one that has come. Yeah, last 2 3 years it has been going ahead, and government is also sponsoring for the. It has also been covered in the insurance also, government insurance also. So we have tried that for a lot of patients, and they are also reaping a lot of benefits because of APD.
Yes, doctor, and these innovations are indeed crucial as disease continue to manifest in various forms over time. Yeah, and doctor, how has the demand for dialysis services evolved post COVID 19? And what challenges has the healthcare system faced in meeting this increased demand?
Yeah, as I said before, COVID almost disrupted the harmony which we had. So during the first COVID wave, what happened? Most of the deaths were not because of COVID, but the people were afraid of COVID. Because they were afraid of COVID, they didn't want to come to the hospital, and they had multiple mortalities were there. And those times, most of the dialysis center were closed because of lack of instruments, lack of uh, even bicarb fluids were in a very high demand. So in first COVID wave, we had a lot of problems in dialysis. In second wave, we were better, but the major thing is even COVID caused multiple renal failure, and we had multiple mortalities because of COVID. And most we had reports of multiple renal failure because of COVID, and because of COVID, a lot of worsening of renal failure and dialysis were there. And the HT population has been increased post COVID, mandatory. And as I said before, the government has been involved has taken a better interest in dialysis patient post COVID. And here in Tamil Nadu, we have seen a lot of increase in dialysis units and increase in dialysis patient even in government setups now. So the patient has increased extraordinarily. It has been increased, and it has been increasing again, because in COVID, you would have known, like, the major treatment was steroids. The only working treatment was steroids, and the only working the steroid worsened the diabetes. And when diabetes has worsened, what happens is it will push the patient into CKD and into dialysis, because diabetes is a major cause of CKD and dialysis in India now. So because of COVID, because of the treatment for COVID, the only treatment which was available, which was only thing was steroid, diabetes worsened. And because of as diabetes worsened, multiple complications of diabetes, we have a lot of CKD patients now because of that. And the major thing is the number of missions have increased, number of uh, centers have increased extraordinarily. When because if I remember rightly, in one of the government institutions, they had around 40 missions before COVID, and they now right now have around 150 missions. It's been tripled, not even doubled, tripled. So this much of the government is sponsoring so much into, and they are putting so much effort into in the benefits of dialysis patients now. So this is how we are managing it somehow.
Yeah, doctor, thank you for providing your insights into the changing landscape of dialysis services. Now, moving ahead, could you please explain the associated complications that can arise from hemodialysis treatment, including issues such as hypotension, muscle cramps, and SS related complications?
As I said before, most of the times, what happens is we have to remove some fluid from the body, because the major function of the kidney is pushing extra fluid outside the body and maintaining the electrolytes the sodium, potassium, creatinine, all electrolytes should be managed. That is a major function of the kidneys. So when the kidney function goes off, what happens is you tend to have a lot of water in your body. You tend to retain all of water because the urine output is almost nil for any dialysis patient. So whatever water intake they take, it stays up in the body. So we usually remove a lot of fluid. The average is amount of like 2 liters to 3 liters of water we remove every session of dialysis. So what happens is when we remove a lot of fluid, and they have some cardiac issue, what happens is they tend to go for hypotension. That is one which is very common. And again, next is cramps. Cramps is again because of fast transition of potassium from intracellular to extracellular time. Again, it can cause cramps. And again, same one, uh, high and fast removal of fluid also can cause cramps. These two are very common. And usually when we deal with this in dialysis unit, we usually cut off uh, the amount of fluid we take, the speed in which we take the fluid. We usually modulate that according to the patient. And when the patient have cramps, we usually give some basic exercises, or we give some L-carnitine also we can try. So these are the two things we do. And other major complications we usually find in dialysis is access problems. So access is, if a patient is in AV fistula, again, AV fistula, we can have thrombus of AV fistula, we can have aneurysms of AV fistula, we can have any bleeds of AV fistula. These are the three major complications. And stenosis again of AV fistula. If these three things happen, it ends the AV fistula journey, and we have to go for a other axis. So these are the major thing. And pseudoaneurysm or aneurysm also can burst, and it can be cumbersome also. So that is about AV fistula. And catheters. So the next form of hemodialysis, other part is catheters. We have central catheters like IJV catheters or femoral catheters. Usual most common complication because of this is the catheter associated infections. Most of the time, the most common infection is MRSA, methicillin resistant Staphylococcus aureus. That's the most commonly seen organism in a dialysis catheter. Next is MSSA, methicillin sensitive Staphylococcus aureus. These are the two major organisms which which causes CLABSI. So these are the major complications which we see. And sometimes we see even hypertension. We can see during dialysis, hypertension, headaches, bleeds from the AV fistula post dialysis. These are the minor complications we see. Uh, so talking about hypertension, as I said before, it could be because of excess fluid to be removed. Sometimes what happens is patient takes multiple hypertension drugs. So usually dialysis patient, they have resistant hypertension. They'll be on 3 to 4 hypertensive medications. So usually they if they take a lot of medications, hypertensive medication before the dialysis, they tend to go for hypotension. Next is because of gastric reflex. So if a patient takes a lot of food during dialysis, what happens is a lot of blood supply will be there to the gastric area. Because of that, even they can have peripheral vasoconstriction, and they can have hypotension. These are the major complications which we find with hemodialysis. And peritoneal dialysis, the major complication, as we discussed before, it is peritonitis. Peritonitis, if it is going to be bacterial peritonitis, we usually give IV antibiotics. And if it is going to be fungal peritonitis, we usually remove the catheter. So these are the major complications because of peritoneal dialysis. And another thing is the catheter could be blocked, or the catheter could be engulfed by the momentum. So for all these, we have to do some reversal surgery has to be done. So these are the major complications we usually face with hemodialysis and peritoneal dialysis.
So, Doctor, moving ahead, can you elaborate on the role of nutrition and fluid management in dialysis patients, and how do you address the nutritional challenge that arise during the treatment?
This fluid, as I said before, usually most of the dialysis patients have zero output. They don't have any urine output. They have around 500 to 100 ml of urine per day. So what we usually advise them is interdialytic weight. That is the weight gain from the end of one dialysis to the next dialysis should be less than 2.5 kgs. So to maintain this, we usually tell them to take around 750 ml of fluid, which means water as well as any other fluid they take. It should be less than 750 ml per day. And this is the first and major point, because when the interdialytic weight raises more than 3 kgs or 4 kgs, they usually have pulmonary edema. So to avoid this, we usually ask them to keep this interdialytic weight around 2.5 to 3 kg, so that they don't have this pulmonary edema. So to maintain that 750 ml of fluid, that is the first point. Next is salt. Salt, we ask them to take half salt diet, which is 3 to 4 grams per day. We we advise only white salt rather than just bring the nutrient of pink salt. Pink salt is potassium based salt. So in any renal failure patient, potassium is always high in patients. So we tend to reduce the potassium in the food in the diet. So we ask them to take white salt, which is around 3 to 4 grams per day. So next point is that. And the next thing is low potassium diet. We request them to take low potassium diet. So about potassium, in vegetables, what happens is we have to avoid green leafy vegetables. Green leafy vegetables in the sense like spinach. We have to avoid cauliflower, broccoli, and next is we have to avoid coconut water. So these are the major thing we have to avoid. And in moderate quantity, we can take potato and potato family. All these root based fruit vegetables, we can take it in a moderate quantity. And all of the vegetables, we can take it in a big rotation, like in 10 days each vegetable can be taken. If a vegetable had been taken today, it can be only taken after 10 days. So this is a easy method of maintaining your potassium in vegetables. And in fruits, patients can take apple, pear, guava, and papaya. And these are the four fruits we usually ask them to take. And we ask them to avoid juices and any soups. So these are the things. In non-vegetarian, we ask them to take eggs every day. Egg white, 1 or 2 egg whites per day. And white meat can be taken. Chicken or fish can be taken. We ask them to avoid red meat. That is because it has a lot of phosphorus. So we ask them to avoid that. And the next major problem a dialysis patient faces is protein intake. So usually what we advise is around 1.2 to 1.4 grams per kg per day. That much of protein has to be taken. A patient who weighs around 60 kg should take around 70 grams of protein. A egg white will have like around 5 grams of protein. So that much of protein the patient has to take every day to maintain his body weight and to maintain his muscle volume, because that's going to be a lot of protein loss during dialysis. That is a major hindrance or major difficulty every dialysis patient faces, because before starting dialysis, we ask them to take low protein. Once we start dialysis, we ask them to take high protein diet, which no one tends to achieve it. So usually what happens is we tend to give them some supplements, protein supplements to take. And we usually ask them to take albumin supplements or whey protein supplements. uh, Whey protein based protein or albumin based protein. These are the two protein which is much more safer for any patient rather than soy based or casein based. So whey protein based and albumin based proteins are the one which is much more safer for any patient who are in dialysis.
Yeah, and Doctor, coming to the last questions, can you explain the benefits and advantage of hemodiafiltration over other dialysis modalities, and what patient populations may particularly benefit from this treatment approach?
Basically, most of the time we don't find a lot of centers having hemodiafiltration. As we talked before, hemodialysis is diffusion. The methodology, which is the basic physiology, is diffusion, and in hemodiafiltration, it is convention. So that is a basic physiology. The diffusion doesn't occur here. Hemofiltration, the physiology is convention, and hemodiafiltration is a combination of convention and diffusion. So the basic physiology convention is happening there. And the size of the pores, as we talked about the dialyzer, there are small pores will be there. The size of the pores are bigger in hemodiafiltration. The size of the pores are bigger. So usually in hemodialysis, what happens is the small molecules are easily removed. Small molecules in the sense like creatinine and urea, potassium, phosphorus are removed very well. But the middle molecules and the large molecules are not removed. They stays up in the body and builds up in the body. But in hemodiafiltration, having a bigger pore, what happens is even this middle molecule and the larger molecules are being removed. The most common large molecule which we face a problem is beta 2 microglobulin. So they tend to usually build up in a dialysis patient, and they can have a type of amyloidosis. They can have some neurogenic pain and bone disorder because of that. So that can be removed with hemodiafiltration. The problem which we face and the technical difficulty we face is in hemodial, as we said, it has a bigger pore. What happens is the chance of infection is very high. So the quality of the water should be very it should be ultra pure water, as we see. So the purity of the water, the level of endotoxins in the water should be very low. So the water has to be ultra pure. That's a difficulty, and a difficulty which we face usually, because the RO plant has to be double RO or triple RO to achieve that thing. One. And next is the machine itself is quite costly, and it is not affordable for each and every unit to keep. And the dialyzer and the consumables are costlier, so which it makes the procedure much more costlier. But the most of the time, who have this beta 2 microglobulin built up in the body, they tend to have a lot of benefit. They reap a lot of benefit with the hemodiafiltration, but it has a very limited spectrum, which means most of the time we tend to skip hemodiafiltration with the view of uh, the finance part, because yes, because for each session, for an average here hemodialysis session might cost around 2.5 thousand, 2500. This might cost you around 10,000, so it is like four times more. So when it is four times more, most of the time the patient is not affordable. Even the insurance doesn't cover that, and that is a major hindrance we face. But as of such, and we know few countries where hemodiafiltration are being used in routine manner also. Uh, I heard like in Malaysia they regularly use hemodiafiltration for patients as in a regular basis. So only if hemodiafiltration comes as a government policy, it's going to be quite difficult for us to do it in a regular basis. But of course, as we talked, like it has a better clearance and better effect when compared to hemodialysis, because it has a middle molecule and larger molecule clearance, higher clearance.
Yes, thank you, Dr. Ajay, for providing a deeper understanding of dialysis options available to individuals with kidney related health concerns. So, Doctor, now we have arrived towards the end of this session. So, thank you, Doctor, for your time and for your sharing your invaluable insights.
Thank you, Harshita, to give me a great opportunity to talk about dialysis. So I think so we can have multiple more conversations like this.
Yes, Doctor, definitely. And huge thank you to our audience for tuning in. And before we conclude, I want to bring your attention to the MedSynapse platform, our vibrant hub that's redefining the healthcare landscape. It serves as an invaluable resource for professional doctors like you, offering opportunities to engage in meaningful discussions, connect with expert doctors, and be part of advancements in healthcare. So why wait? Explore the MedSynapse platform right now to make the most of these remarkable opportunities. And feel free to drop your comment in the section below if you have any questions. We'll be more than happy to provide you with answers you seek. Until next time, take care and keep advancing in your medical journey. Goodbye.